Welcome, bienvenue. Welcome back from summer break. Back to the CanCOVID Speaker Series on Tuesday afternoons at 4 o'clock. CanCOVID is now powered by the Real platform. You'll be hearing more about that later and more information will be rolling out. I also wanted to let everyone know that we're working on putting together some knowledge mobilization workshops. They'll be called Knowledge to Action. And so this is the perfect speaker series event to be kicking off this with this evidence synthesis. So without further delay, I would like to get to that. There will be time for your questions at the end. Please feel free to type your questions in the chat box and I will read them out for our YouTube viewers who are catching us later. And if there's any need for a clarification or if I butcher some pronunciations, please feel free to turn yourself on and respond vocally. Thank you so much. So without further ado, John Levis and Jeremy Grimshaw, take it away.
Thank you a lot, Kimberly. So this is Jeremy Grimshaw, and with John Levis for the next 20 minutes, we're going to very quickly take you through the activities of COVID, which was a response to try and help coordinate the global evidence synthesis activities to inform evidence or to allow evidence-informed decision-making in COVID. We're going to move through the slides quite quickly, and I apologize for that, but hopefully you can keep up to date and handle my rather weird accent. So, okay. So just as background, I don't really have to tell you that COVID-19 has been one of the greatest health and social threats that we've faced in many decades. One of the results of that is that different decision makers have been basically actually seeking evidence on prevention, management and mitigation of the impacts of COVID-19. And we've seen a dramatic increase in both basic and applied research, although to a lesser extent social and economic research. But one of the challenges about this is that individual studies are rarely sufficient by themselves to inform policy or clinical or individual decisions. So instead of focusing on individual studies, which we often see being basically dissected in media, what we need to do is think about how do we look at the global evidence base around a particular topic. And so we would argue very strongly that we should be using evidence syntheses that use formal, explicit, rigorous methods to bring together the findings of studies already completed to inform key decisions that we're making at a policy, a practice, or an individual level. Evidence syntheses comprise a very broad range of methods that we can apply to a wide range of questions, including reviews of basic science studies, epidemiological data, diagnostic test performance, effectiveness of treatments and preventive interventions, and reviews of patients' experiences with interventions and how and why the interventions work. So, basically, it's a way of interrogating the global evidence that can be applied to basically any form of question. And the reason why we think evidence syntheses are so important is they reduce the likelihood that decision makers will be misled by research because they're more systematic and transparent in the identification, selection, appraisal, and synthesis of studies. At the moment, we see a lot of people sort of basically highlighting a single study that somehow reinforces their perspective rather than looking at the global evidence, since evidence syntheses allow us to look at that in a very transparent way. It increases confidence among decision makers about what can be expected from an intervention or what can be is likely to be driving the epidemiology of COVID because it's increasing the number of units for study. So a single study, it might look an intervention might look promising, or it might feel like we have a good handle on the extent to which there is, say, airborne transmission. But actually, if we can demonstrate across repeated studies that those interventions or transmission routes are what we think they are, then that is a much more powerful message. It also allows decision makers to focus on appraising the local ability of reviews rather than having to do them themselves. So actually doing evidence syntheses is a technical job. What's much better is you actually allow those decision makers to think, okay, someone's done a good review a high quality review for me. Now let me think about what it actually means for my community. And then one of the other factors is by putting all of the evidence out there, it allows stakeholders, which might include public interest or civil society groups, to start to constructively contest the research evidence because it's laid out for them in a more systematic and transparent way. We have colleagues in Oxford who have both looked at in the same unit, have looked at the evidence on mask wearing and have come to directly opposite conclusions, not because they disagree what the evidence means, but what the interpretation is and also what the implications are. So having all the same evidence out there allows people to actually think through what they think it means. So what did we see during we were using the term sprint for the first 3 or 4 months of the COVID pandemic, which when it was chaotic, there's a lot of fear, a lot of uncertainty. People didn't understand the basics of this disease. And as well as a sort of a huge amount of primary research, we saw a substantial increase in evidence synthesis and supporting activities, which was a really positive sort of development. However, what we observed was there were a lot of people who were rushing to do syntheses who maybe hadn't done them before or didn't have a lot of expertise in them. And that meant that often the reviews were of variable quality or transparency. There's an initial focus on the rapid reviews, large on clinical and public health topics. And one of the challenges was that the evidence base here is moving ahead so quickly that if you did a rapid review, say in the beginning of April, it would have been out of date by mid-April. And so the problem about focusing on rapid reviews is that basically it gives a very tiny snapshot of what we know now, but doesn't help given the rapid evolution of the evidence. There's a considerable duplication of effort, and there are a range of issues around whether we could actually find these reviews, because often they were in the grey literature. So there are a number of issues that came up through this initial phase that, although it's a very positive response to COVID, we basically thought that there's a major noise to signal problem within this. And if you're a decision maker in a public health unit in, say, Ontario, actually trying to find high quality, up-to-date evidence was a major challenge despite all this activity around you. So John, I think I'm handing over to you now.
Yep, great. Thanks, Jeremy. So COVIDend is a time-limited network that came together really to try to reduce the noise-to-signal ratio that Jeremy's talked about, to make the most of the existing evidence ecosystem, make it even more robust and resilient in future, but very importantly, not to create new institutions and processes where they exist, but to really focus on strengthening them. And while our focus, as you can tell, is evidence synthesis, a lot of what we're doing has spillover effects to those engaged in methodological research, infrastructure, and so on. Jeremy, if we go to the next slide, I think you'll get a feel for the 50 partners we have within COVIDend. They reach to every WHO region, cover all the WHO languages, span the spectrum from public health to clinical to health systems to economic and social responses. So really an incredible group of people that have banded together to try and make the most of this interest in evidence. If we go on to the next slide, you'll see the first set of our achievements. You can read more about them on our website. One of the first things we did was create a guide to COVID-19 evidence sources with the high yield, high quality sources of evidence. Many of these are not published. They're sitting on a website, so we provide them in a guide. Many of us in Ontario, when we're asked for a 4-hour turnaround from government on what we know, our colleagues across Canada and our colleagues across the globe use this guide when they're asked to bring together the evidence on a topic. Something that we have a prototype of up on the website now, but within another few days, we'll have a fully searchable living hub of COVID-19 knowledge hubs. So there are now at least 250 groups in the world who are focused full-time on pulling together different types of data, different types of studies, different types of evidence syntheses. And if you're sitting in Ghana and want a particular type of knowledge hub, you can use this hub to identify it. Same for Canada. Third, we came up with a taxonomy, mutually exclusive, collectively exhaustive list of the types of decisions that will be needed related to the COVID-19 pandemic and the pandemic response. And that covers public health measures, clinical management, health system arrangements, and the full spectrum of economic and social responses. And I'll come back to that in a minute. If we go to the next slide, we also put together principles and resources to support evidence packaging for decision makers. So decision makers do not want to read 150-page reports, and there's a science of how do we best package and disseminate research evidence for decision makers. So we pulled that together. We described an evidence support model that we first pioneered here in Ontario that's now been taken up in many countries around the world to produce rapid evidence profiles in timelines as short as 3 to 4 hours. We developed tips and tools for those working actively with decision makers to help them understand how to find and use the best evidence. We developed an interactive flow diagram that points you to, depending on where you are in that flow diagram, to resources to help you if you're considering or conducting an evidence synthesis. And we're working in partnership with WHO and Cochrane as the Secretariat for the WHO Evidence Collaborative for COVID-19. So back to you, Jeremy.
So just to say this also, we started COVID End about mid-April. So everything that John said was actually delivered in the first 8 to 10 weeks of COVID End. What became apparent is that we are now moving into the marathon phase. You've got through the initial phase, which was somewhat chaotic, very scary, and we now know that COVID is going to be with us for 12, 18, 24 months or longer. And so, we started to think about this as a marathon phase. And what should we be doing? What should the evidence synthesis response be during the marathon phase? And we believe that the world will be best served if we have a global stock of high quality, accessible and actionable living systematic reviews that address the most important healthcare, public health, health system, economic and social issues faced by decision makers. I bolded the health system and economic and social issues because those are areas where at the moment we have many or much fewer reviews available. We need evidence synthesis capacity to undertake high priority systematic reviews efficiently where they're needed, i.e. where we don't have high quality living systematic reviews. We need local evidence support initiatives to enable decision makers to find, interpret and contextualize the evidence to meet their needs, and a global evidence infrastructure to build on these existing organizations to better coordinate and prioritize this work globally, so we're sharing our effort and sharing the benefits from that. And finally, we need secure funding to handle that. So I'm going to hand back to John, and he's going to talk about some responses to the marathon phase that we are now working on.
Yeah, so 4 things that we're focused on with COVID End right now as we enter the marathon phase. One is an inventory. So the prototypical user of this, in our view, is the 25-year-old policy analyst in a Ministry of Health, whether they're in Ontario, Argentina, or Zambia, who's routinely asked, what do we know about X related to COVID-19? So this is an inventory of, for any given decision, the, in quotation marks, best evidence synthesis for that decision. So we, instead of having to work through the guide that we talked about before, we have harvested all of those sources. We go back, we will, once we reach steady state, go back to them every week, identify any new evidence syntheses, apply the filters from the COVID End taxonomy, so it maps directly onto the taxonomy, and then we use 3 criteria to identify either the single best evidence syntheses or several of them if they are competing in terms of the recency of the search, the quality of the evidence synthesis, and the availability of an evidence profile. Then, to help the 25-year-old policy analyst, we reword the title of the evidence synthesis to support a relevance assessment. So we give them a sense of what types of people were involved, what's being looked at, what types of outcomes, and then also what kind of evidence. Did we find evidence? Did we find high quality evidence? And so on. On the next slide, some of the additional flags that we put in are, is it a living evidence document? Because knowing what we know about quarantine this week might change in 3 weeks, and the 25-year-old policy analyst might be asked, well, has anything changed? So they need to be able to zero in on those living evidence documents, the type of synthesis, and the type of question it addresses. And we're increasingly setting ourselves up so we can share these data with other people that are maintaining different types of databases. On to the next slide, which I believe, if I remember correctly, will give you a sense of what the inventory looks like in a compressed state. So we focus on a decision like wearing masks. We give you the date of the last search. We give you the quality rating for the review. We tell you whether there's an evidence profile, and then we have the declarative title. The more extended version adds the columns in the lower right corner. Is it living? What type of synthesis? What type of question? And then the citation. On to the next slide. Second thing that we're obsessing about these days is making sure we're keeping abreast of recurrent and emerging issues for which we need evidence syntheses. So we've struck a global horizon scanning panel. We have people like the senior advisor to the Prime Minister of Australia, the head of the monitoring and evaluation unit in the Office of the Presidency of South Africa. We have consumers, providers, health system leaders, economic and social policymakers, and we're really trying to get coverage across every WHO region, across every WHO language, and also across the different parts of the taxonomy: public health, clinical management, health system, and economic and social response. What we're looking for from these people are what are the big priority issues so that we can help to then drive the production of living reviews on those priorities. On to the next slide. So coming out of that work, then we'll have a continuously updated list of priority topics where living systematic reviews are desperately needed. And then we'll be progressing to cajoling, encouraging, nudging groups to take responsibility for these living reviews going forward. The next slide is my last one, I believe, the COVID and Community Listserv. This is really targeted at those like ourselves, like our colleagues in government in Ontario, like our peers around the world who are at the coalface of trying to support decision-making. So if you are someone who has these attributes, or you know of someone who is, ask them if they want to join the COVID and Community Listserv. So you're creating or using evidence syntheses to support decision-making. You're engaging with decision makers, whether those be citizens, providers, or policymakers. You're keen to learn from others about how to support decision-making, and you share the values of the COVID-N partnership, which you'll find on the website. So we just started this recently. We're up to 250 plus members from around the globe. A great place to learn about how you can better support decision-making about COVID-19. I think the next slide, Jeremy, is back to you for a quick wrap up.
So sorry, you can see that John and I don't actually breathe when we talk. We try to get through this very quickly, but I mean, just to summarize, you know, there's been an explosion of primary COVID-related research that needs to be appraised and summarized in evidence syntheses, so that whether they're ministries of health or public health units or clinicians or citizens trying to think about how they respond to COVID, they have high quality summaries of the global evidence base to inform what they do. The initial phase of the pandemic was really sort of characterized by a lot of activity, but actually quite a lot of noise to signal in terms of the evidence phase, with rapid reviews of variable quality that were quickly out of date, a huge duplication of effort, to moving towards more of a high signal to noise evidence phase, where we have curated, high quality living evidence syntheses and evidence support initiatives. And the COVID End is working with many of the key global evidence synthesis and evidence support organizations around the world, with groups like WHO, to try and sort of basically better coordinate and enhance the sort of evidence synthesis response during the next phase. And the final slide is here. If you're interested in knowing what about this work, please go to our website. You'll find everything we do is up there. Everything is open access. If you're interested in joining the community listserv, then follow the link there, but you can also get to that through our website. Feel free to email us if you want further information, and follow us on Twitter and help amplify the messages as we go forward. So thank you very much. I think we're going to pass back to Kimberly to handle the questions.
That's fantastic. Please take one moment, take a deep breath.
If it was an hour later, we could have a glass of wine. Jeremy can, because he's an hour and a half ahead of me.
I wanted to ask you, would you be able to share your PowerPoint deck with me? I could post it in CanCOVID, and
absolutely,
anyone who asks who's listening.
Yeah, and Yes, absolutely, Kimberly. I'm sorry to interrupt, but I was going to say we're about to add a presentations page on the COVIDN website also. So if at any time people are looking for the most recent overview slides on COVIDN, they'll also find them there, but we'll for sure share them with you.
Fantastic. That's great. Oh, and that's what the first question is. Would you be able to share the deck? So taking care of that. But if anyone else has any questions, please feel free to launch them into the chat box. And we're not too large of a group today, so if you like, you could also ask them yourself. Just turn off your microphone, turn on your microphone, and ask it vocally. How large is your team that you're doing with this? This is incredible work.
I think we probably, so we have kind of three senior folks, myself, Jeremy. It feels some days like it, certainly during the peak of summer, I think we were kind of 12, 14-hour days, 5 to 7 days a week. But the staff team is probably about 4 FTE folks. So we're doing it, you know, it's a jerry-rigged system, and we're reliant on a huge amount of volunteer effort. We also have 7 working groups with world leaders in every one of those domains from around the globe. So they're volunteering their time as well. And then, as I mentioned before, we have 50 partners, all the best evidence synthesis groups around the world, or many of the most prominent ones that cut across all areas of the COVID-19 response.
Yeah,
so
yeah.
we're blessed by the volunteer effort. And
It's
one thing before I forget that I was going to say about the inventory, we're always thinking about how to improve it. We're just about to start to promote it because we still have to clear the backlog of existing evidence syntheses, and then it'll be updated every week. We're looking at also adding columns for whether and how the syntheses addressed equity considerations. So did they target vulnerable populations? Did they take an equity lens to their work as well?
Oh, that's fantastic. I see that Vivek turned his monitor on, so I think you have a question.
Okay. Hi, Vivek.
Jeremy and John, that was a great presentation. It's an incredible amount of work, and I hope that this lives on after COVID, because it's obviously going to be a great network and resources. As I saw your 4 major pillars, like you're really targeting the key users of evidence synthesis in your work. A lot of the noise that Jeremy talked about has been coming, in my view, from particularly the media and the public picking up on single studies. Mm-hmm. Do you have any antidotes to that, or how do you see getting those people that are harping on every single, and now we even have things like, you know, events in clinical trials, like when they stopped the Oxford trial last week, getting headlines around the world. It's a little off of the synthesis question, but since you're working on this, I thought I'd ask you what your thoughts are.
Jeremy, do you want to go?
Yeah, so a couple of things. I mean, we know that actually by presenting the evidence to people, that's one of the ways of, you know, basically toning this down. There are groups, so colleagues in Evidence Synthesis Ireland have basically a sort of a fact checker for COVID. So and within Ireland, they're basically, as things come out in the news, they're very rapidly trying to push out, here's what the evidence tells us, and be able to sort of say, well, it's actually quite common. For example, for trials to be paused while we look to see if there's a major issue, doesn't mean this is a major problem beyond that. You know, one of the issues is that those things need to be resourced. What happens in a lot of the evidence synthesis work globally is this is all being done off the side of people's desks. And I think one of the things we have to think as a society is, how do you want to do this? So we actually are trying to help our citizens and our decision makers, our public decision makers, make the best evidence. So I think we have some ideas about how to do that. There are international examples of that we could use, but I don't think in CADA we have, beyond Andre Picard probably, any sort of publicly funded systems that are trying to sort of address that misinformation.
And I would just add a few things. So one is that on our evidence packaging webpage, we talk about a lot of the ways of dealing with this, and we profile really courageous efforts to take these types of issues on. So you'll see a list of what we think exemplars of trying to raise the level of debate in the media about what types of science we need to focus on. And we have some incredible journalists who are working with us trying to figure out, should really what we do be briefing editors of major newspapers, magazines, and so on, to help them to appreciate this. Once most people hear it, they get it, but it's just that they're not exposed to it. The second people beyond the media is we finally have acted on the feedback from our many citizen leaders that are connected to COVID, and we're developing a citizen engagement strategy. And one of the pieces that they think they can do is start to get out there as citizens to raise the heat on the media, on politicians and others who are falling back onto single studies. But boy, is it a perennial challenge. And I really think we can do a better job on this in Canada, but also globally. So great point, Vivek.
Yeah. Barbara Smith from the BC Ministry of Health asks, any advice on how to connect ministry priorities with existing evidence, because things are changing so rapidly?
How to connect ministry priorities with existing evidence. Well, I guess, what we've tried to do with the inventory is flip it around and say, we think we can list out all of the likely decisions that as ministries you are going to have to face. And then we are going to try to find, is there existing high quality living evidence syntheses on those topics? And if not, we're going to try and fill the gap. So if you go to the inventory and you believe that there are major decisions that you're facing that aren't represented, we're very happy to add them. We've had 3 meetings of our monthly meetings of our global horizon scanning panel, and they are identifying issues like long COVID, a variety of issues that we really need to have living evidence syntheses about. So but again, if you see them from your perspective, from a ministry perspective, we're missing them, let us know what they are, and then we'll add them into the inventory. But no matter how comprehensive that list is, our experience is we've now done about 28 or 30 rapid evidence profiles for the Ontario Ministry of Health. They always want it packaged to a very particular issue. So we might have 3 great living evidence syntheses on masks, but the specific question becomes, what is the age cutoff? 5 years and up in schools, 7 and older, teenagers, what's the logical kind of mask cutoff? So for those, we can always do deep dives with these rapid evidence profiles and encourage the folks doing living evidence syntheses to include those nuances going forward.
That's great. I think Simon has a question.
Yeah, Simon looked like he was going to jump out of the little video box. So go, Simon.
No problem. Thank you very much for a great presentation. Sorry, I was reacting before to some of the journalist things, but that wasn't my question.
Okay.
One of the things, obviously, that COVID has really created in terms of a challenge, in terms of evidence, is the amount that's being pushed out and the variety of forums, and a lot of criticism around the lack of peer review and the volume, et cetera, et cetera. So I'm just, curious to get both of your takes on what is happening here and how best to navigate through this. And even from a scientist perspective, how do we make sense of all of these different places where information is being pushed out to?
Jeremy, do you want to go, and then I'll jump in?
Sure. So Simon, I think this is a real, this is one of the major challenges. Vivek alluded to, this kind of anecdotes in newspapers that are being taken as somehow hard, robust evidence. Our first approach would be that actually this is why evidence syntheses are vitally important. Doing an evidence synthesis requires you to look very critically at the individual studies to work out what the strengths and weaknesses of those studies are, and to use that in your interpretation of what the global evidence base is. So we would argue that actually by having high quality evidence syntheses available, that's one of the protections around this. I think what we need to do is we need to work with a range of decision makers to try and make a greater awareness of evidence syntheses. So for example, the WHO has asked us to work with them on a position paper where we particularly articulate this as an issue and this idea of living systematic reviews as being one of the solutions to that. One of the other things is that people have the channels that they go to. And I think what we're trying to do through the inventory and through working with partners on the inventory is make sure that across a range of different channels, high quality is available and the maximum information about that high quality evidence is available for them. So it's a real challenge, and we hope that by the work we're doing is actually trying to reduce some of this noise to signal, or at least they're saying, go to some of these high quality sources before you Google. Because Googling, you're going to get the wacko stuff as well as the good stuff, but the good stuff might be 3 pages down.
So if I just add a little bit of precision, actually, really what I was very specifically meaning was, we have a lot of high quality evidence, but it's not being peer reviewed, right? And there's lots of repositories where this is being dumped into. So and I think that's specifically what I was talking about, and the challenge is that's going to create all the change in emphasis that this is going to push in terms of from the academic perspective.
Well, so we hope we will eventually get into the peer-reviewed literature. A lot of them are kind of preprints, but evidence syntheses should look at both published and unpublished literature. So we have partners who are rapidly trying to develop repositories of COVID stuff, and they're going to the preprint servers. They're going to the clinical trials registries. So all of this stuff is being surfaced. But one of the challenges about preprints is that there's an awful lot of stuff that's being put up, which is, pardon my English, but just crap. Basically, I think by using an evidence synthesis perspective, that, for example, was one of the ways of starting to really tease apart how some of the early French studies on hydroxychloroquine were pretty shoddy and actually shouldn't be given the space. So evidence synthesis actually, they need to consider this high quality, the published and unpublished. We have increasing ways of collecting and collating the unpublished stuff. And then we can look at it with an appropriate level of scrutiny and sort of say, here's still, we actually don't think this is reliable, or here's the things that we still need to know about this, hopefully in a way that might also improve the actual final paper.
And if I can just add, I would just say, I guess I'm not entirely convinced that peer review always functions that effectively at distinguishing the high quality from the low. But what we're trying to do with COVIDend is rate the quality of the evidence syntheses. And part of a good quality evidence synthesis is having assessed the quality of the studies that were included in the review. So we're not taking peer review as a proxy for quality. We're saying the scientists doing the evidence synthesis need to systematically work through using explicit criteria and assessment of the quality of each of the included studies, and then give greater weight to the higher quality ones. So that would be part of the response. But Simon, if you have additional advice for us about how we can do better, we're very open to feedback, as we are for anyone on the call.
No, I agree 100%. It's the challenge with the COVID astronaut was amazing.
Yep. That has all been fantastic. That is our time. There was some questions. Thank you so much, John, for answering them in the chat box. So that's motivation to attend live if you're watching this on YouTube. But I'd like to thank you so much for such a fantastic presentation and all of the great questions. And we'll see you next time. Thank you so much.
Thanks for the opportunity. Thanks, everybody. Bye-bye.